Hello everyone, today we will talk about assessment of hearing loss. To assess the hearing, we use pure tones. What are pure tones? Pure tones are the sounds of single frequency, also known as sinusoidal wave or sine tone. We use pure tones to assess the hearing capacity of the ear. Qualitative and quantitative assessment of hearing loss. We use these pure tones in tunic fork test and pure tone audiometry. Tunic fork test. What is tunic fork? Tunic fork is looks like this. It is either made up of steel, magnesium, or aluminium. Various frequencies 128 Hz to 2048 frequency of tunic forks are available. Commonly used is 512 Hz. Various type of tuning fork test is Rene Weber, absolute bone conduction, Schwabeck and Gelle. So this is how the tuning fork looks like. It has two prongs, base, shoulder, stem, and footpiece. Prongs we use for air conduction, footpiece we use for bone conduction. How? Air conduction, we strike the tuning fork over the hard surface, the prongs of tuning fork over the hard surface. We will keep these prongs closer to the ear, not touching the ear, approximately 2 centimeter away from the external auditory meatus. Sound waves will travel through the system, that is external ear, middle ear to the inner ear till the auditory cortex. So what it assesses? It assesses conductive mechanism and cochlea. This is air conduction. Now talk about bone conduction. The foot plate of the tuning fork after vibrating kept over the mastoid, and this particular bone conduction measures the cochlear function of the ear. Normally, air conduction is more than bone conduction. Now, this is Rene test. First tunic fork test is Rene test. In this, we hit the prongs, we keep it in front of the external auditory meatus. Once patients say that I am not able to hear to the air conduction, we immediately take the footpiece and keep it over the mastoid to assess if air conduction is more or bone conduction is more. Interpretation of Rene test is as follows. Rin is positive. Positive means air conduction more than bone conduction is positive. Where is it seen? It is seen in normal hearing or SNHL, which is not profound. Any degree of SNHL but not profound. Rin negative means bone conduction more than air conduction. Where is it seen? In conductive hearing loss. Now, in first beginning, we told that Rene positive is seen in SNHL other than profound. So, what is seen in profound SNHL? And normally, SNHL will have positive, that is air conduction more than bone conduction. But if the patient is having profound SNHL, then there will be intracranial conduction of the bone. Bone conduction will happen from the contralateral ear. So what will happen? The affected ear will listen to the bone conduction due to the intracranial conduction. So due to which patient will have bone conduction more than air conduction. Air conduction is not there because it is profound SNSL. So there will be bone conduction interpreted as more than air conduction. It is called false negative Rene test seen in profound SNHL. Talking about Weber test. In Weber test, we use the footpiece of the tunic fork. We again strike the tunic fork prongs. We put the footpiece over the forehead or the vertex. We ask the patient if the patient can hear the tone equally on both the sides or it is more in one ear, right or left ear. Interpretation of Weber test is as follows. Normal hearing, tone is heard centrally, means equally on both the sides. SNHL, sound is heard on the better cochlea, like the ear which is not having the SNHL, which is normal ear, the sound will go towards that side. But in conductive hearing loss, the sound is heard in the affected ear, poorer hearing ear. So, conductive hearing loss, the sound of the Weber test will go towards the affected ear. In SNHL, the sound of the Weber test will go towards the normal ear. So, this is the place where we use to keep the footpiece of tunic fork. Now, absolute bone conduction and Schwabeck test, they are sister tests. Why are they sister tests? Because both of them are testing same thing. There is a difference of only one component of technique. What is that component? That is obliteration of the external auditory meatus with the pressure over the tragus. So as name applies, absolute means we are only seeing the conduction of the bone, absolute bone conduction. So in which we are definitely blocking the air conduction component by pressing over the tragus. But this particular maneuver, we are not doing it in Schwabeck. We are simply keeping the foot piece over the mastoid without occluding the external auditory meatus. This is Schwabeck, and pressing over it and keeping this over the mastoid. This is absolute bone conduction. So, assuming that examiner is having a normal hearing, once we keep the footpiece over the mastoid and patient say that I am not able to hear it anymore, we immediately take the tunic fork from the patient and shift it on the examiner. If examiner is still able to hear, it means examiner has more bone conduction than patient. Interpretation of absolute bone conduction is normally equal to examiner. In conductive hearing loss, again equal to examiner. In SNHL, it is reduced in comparison to the examiner. Gallet test. In Gallet test, what is the mechanism? What is the principle behind Gallet test? Now, when we increase the pressure of the external auditory canal, when we increase the pressure of external auditory canal with the help of Schiegel's speculum, the pressure pushes the tympanic membrane and ossicles inwards, raises the intra-labyrinthine pressure. It causes immobility of the basilar membrane, leading to decreased hearing. This is normal. But if this particular mechanism is not present, why? Because of the fixation of the ossicles, then Gallet test will come negative. It means increase in pressure of the external auditory canal with the help of Schiegel's speculums makes no difference in the amount of time the sound is heard. So that is called Gallet test. It is usually seen to check the component of the conductive hearing loss due to ossicular fixation. Summary is, let's talk about conductive and sensorineural hearing loss assessment with the help of tunic fork sitting in OPD. Rene test, negative in conductive, positive in SNHL. Now, Weber test. It is lateralized to poorer ear in conductive, but it will be lateralized to better ear in SNHL. So with these two tests, we get to know this is SNHL or it is which ear. Then absolute bone conduction. It is same as examiner for conductive hearing loss. For SNHL, it is reduced. For Schwabeck test, it is lengthened. What we do in Schwabeck test, we see the time for amount of time it is seen. So it will confuse you. Let's confine ourselves to Rene, Weber and absolute bone conduction. Gallet is for the pressure due to ossicular discontinuity or ossicular fixation. That is different. Now coming to a question. Patient is having positive Rene test in both the ears and Weber lateralized to the right ear. Positive means air conduction more than bone conduction. It means patient is not having the conductive hearing loss. Patient is having the SNHL. Now SNHL, it can be either right SNHL or it can be either left SNHL. How do we get to know? In SNHL, Weber is lateralized to the normal ear. So opposite ear is affected. Here, Weber is lateralized to the normal, that is right ear. So here the answer will be left SNHL. So this is the right answer. This is one of the easiest example. There will be many other in your MCQ. So now let's talk about, apart from tunic fork test, we do some audiometric assessment with the help of particular instruments. What are those tests? One is pure tone audiometry, in which we use pure tones and we make a graphs at different frequencies. Then speech audiometry, in which we use speech. Spondy words are used and we see how the patient is perceiving the speech. Then impedance audiometry. Impedance is the resistance to the sound energy. So this resistance in the middle ear is checked with the help of impedance audiometry. Backese audiometry, in which it is the automated one. We provide pulsed tone to the patient and it is automated, in which the patient press a button and the machine will automatically increase the frequency and intensity of the sound. And there is Bera. That is the last test. Now let's talk about pure tone audiometry. This is how the setup of a pure tone audiometry looks like. Insulated room from the sound, patient is sitting inside. This is the patient, examiner is sitting outside. Patient is having an alarm in her hand and earphones on the ear. When the patient can hear the sound, they will press the button. If they do not hear the sound, there will be another button for that, so that the examiner can increase the frequency and intensity of the sound. So, in this soundproof room, person is sitting comfortably. First, we check air conduction, then we check bone conduction. Air conduction, we use headphones, and for bone conduction, we use vibrators. Masking sound, we will talk in next slide. We start with 125 hertz frequency with 0 decibel. Step by step, increase the intensity 5 decibel. Once particular frequency has been checked to certain level of decibel, we increase the frequency again starting from 0 to particular amount of decibel. We keep on marking the thresholds on a graphic picture and we join them to make a graph of it. How to assess, how to interpret PTA, we'll see it after masking. Now, what is masking? Masking presents a constant noise to the non-test ear so that the non-test ear is acoustically blocked and does not participate in hearing test. So it helps in assessing the ear hearing loss in closer to the particular amount the patient is suffering from, because it is useful in certain cases where we are not screening very a good number of patients. When we are seeing or screening so many patients, at that time masking slows down the process, we use the normal one. But when we have to assess patients specifically for hearing aid assessment or prognosis of any treatment or any disease which is life threatening or something, in certain cases we usually use the masking to be more precise in our assessment. Now, symbols. To particularly read the PTA graph, we need to know what symbol represent what in that particular graph. To remember it, first remember that R for red, R for right, and red. So, whenever if there is the color coding is not present, then there are different marks. But if we know that color coding is present, then red means for right ear, blue means for left ear. If by chance color coding is not present, then how will we interpret? This particular cross mark is for left ear and this circle is for right ear. Now, if we are doing the masking, this is about air conduction. Remember, this is about air conduction. Cross and circle is for air conduction. And for bone conduction, we use this arrow. Arrow is open on the left side, it means it is the left ear. If arrow is open on the right side, it means it is the right ear. This is normal hearing assessment without masking. When we mask, then air conduction symbol for the left ear will change to square and for the right ear will change to triangle. And similarly, bone conduction, other than the arrow, this particular type of mark is used like this. The opening will be same. Open on the left side, left ear, open on the right side, right ear. And there are few others like this. I would not like to explain right now. It will confuse you a lot. You can see it later to have an idea, because these particular questions will be very rare. You will be basically playing around with air conduction, bone conduction, with masking, without masking. Now, what are the indications for PTA to understand the degree of hearing loss, amount of hearing loss? Type of hearing loss: conductive, SNHL or mixed hearing loss, progression of certain diseases like Meniere's and autosclerosis, prognosis of the treatment, response to the treatment if patient is giving or not. Hearing aid, when we have to give patient hearing aid, we need to know that what particular frequency, what amount of hearing loss is there to customize the hearing aid according to the patient's hearing loss. Type of handicap, like patient is having severe, moderately severe or profound hearing loss in one and both the ears. Depending on that, different governments have different particular criterias to mark it as a handicap quota. Now, talk about the PTA graphs. We know that air conduction and bone conduction we use to assess in PTA, and air conduction is mostly more than bone conduction. So the graph will be, there will be a difference of hardly 5 to 10 decibel between the bone conduction and air conduction, in which air conduction is above and bone conduction is below. But when they are closer to each other, but above 20 decibel, which is the normal threshold of hearing, it is normal. Same with the right ear, they are closer to each other but above 20, it's normal. This is for right ear, this is for left ear. Conductive hearing loss, we know bone conduction is not affected. Air conduction goes down, so there will be gap between bone conduction above and air conduction below. This particular air bone gap, it is seen in conductive hearing loss. SNHL, in this bone conduction, air conduction both goes down. So both graphs sync together. Depending on the amount of hearing loss, WHO criteria, mild, moderate, severe, and profound hearing loss will be assessed accordingly. Here in this graph, we can see patient is having profound SNHL. Speech audiometry, as I have told you, in this we provide speech or words. What type of words we provide to the patient? Spondy words. What is spondy words? Spondy words is two-syllable unit. Equal stress is given on both the syllables. Childhood, Woodstock. This is spondy words, right? So we provide spondy words to the patient, and patient is asked to either repeat the word or write the word. And the number of words patient can write or repeat, we make a percentage of it. What we all assess in the speech audiometry, there are two parameters we assess. One is speech threshold score, second is speech discrimination score. Speech discrimination score is the most important parameter. It is normally 95 to 100%. It means out of 100 words, patient can repeat 95 to 100 or can write properly 95 to 100. That is a normal speech discrimination score. In cochlear lesion, SDS is low. And if we talk about retrocochlear and the cochlear lesions, in retrocochlear lesions, SDS is very poor. And plus, the rollover phenomena is present. When we increase the decibel or intensity of the sound, the SDS keep on decreasing because there is a recruitment in the retrocochlear lesion. Now, as poor discrimination score less than 80%, here it is 80%, but now we have made some advancements in the hearing aids like mobile phones, the upgradation is always there. Now it is 60% or 70% sometimes. If the patient SDS score is less than 70 or 60%, then patient is not the right candidate for the hearing aid because patient cannot discriminate the sound. Next is impedance audiometry. Before doing the impedance audiometry, let's understand what is compliance and impedance. Compliance is it's the ease with which the sound energy can flow through the system, external ear, middle ear to the inner ear. And impedance is the resistance sound energy face while traveling through the same system. So in impedance audiometry, we measure the impedance. There are two ways of measuring the impedance. Similarly, there are two tests in impedance audiometry. One is tympanometry, second is acoustic reflex. Now let's read about it. Tympanometry is to measure the impedance of the middle ear at the level of tympanic membrane in response to the pressure changes in the external auditory canal. These things will remain same in acoustic reflex, but here the stimulus is loud, that is sound stimulus. Here it is pressure. Now let's talk about tympanometry. First, this is the objective test. The tympanometry and acoustic reflex, the both are objective tests. They help us to differentiate between conductive and sensory neural hearing loss. For conductive hearing loss, it helps in diagnosing the cause behind the conductive hearing loss. In SNHL, it helps to differentiate the cochlear and retrocochlear lesions. Measurement of the middle ear pressure, eustachian tube functioning, and to identify site of lesion in the facial nerve. So all these are the benefits of impedance audiometry. Now, this is important for your MCQs and your question paper as well as Viva, oral Viva. So we should understand what are the graphs we obtain in the tympanometry part of impedance audiometry. So there is y-axis and this is x-axis. In x-axis is the pressure of the middle ear. In y-axis is compliance. Compliance is the resistance or the ease with which the sound energy flows. The gold standard is A. In A, the pressure is 0 and there is a typical amount of compliance which is present. If the compliance, normal amount of compliance is not present in your ear, you will be sensitive to each and every sound around your surrounding. Now, there are four major graphs. A is normal. Other than that, depending on the etiology, there are four major graphs of tympanogram. One is AS. in which there is S means stiffness. So stiffness in this, there is decrease in the y-axis. I mean the tympanic membrane become quite stiff. It can happen in autosclerosis or very thick tympanic membrane, autosclerosis or any fixation of the ossicular thing. There is tumor in the middle ear like glomus jugular. In certain cases, the compliance will be decreased in which there is a stiffness of the tympanic membrane and the graph is AS type. This is the AS type of graph where this particular y-axis are affected but x-axis is normal. Same way, if it happens on the other side, like x-axis again, x-axis is normal but y-axis increases, it means now it is opposite to fixation. It means discontinuity of the ossicles, or it can be lax or very thin tympanic membrane. This is AD type. So we have done A, AS, AD. Now there are two more, AC and AB. C is like this, so we can see there is a negative, like it is going inside. So it is creating negative pressure in the middle ear. So this is C. So what will happen? In C, your x-axis will be affected. It will go negative and y will be normal. And where is it seen? This particular C, this is seen in eustachian tube dysfunctioning. Last graph is AB type in which both X and Y are affected. And it is seen in cases when there is a fluid or there is glue ear, something in the middle ear. So let's check about it. AS is we have done. AD we have done. AC we have done, that is early stages of eustachian blockage. AB is serous otitis media or adhesive otitis media. So you can go through it once again. Once you understand the concept, there is no need to mug up. Now, the second part of the impedance audiometry is acoustic or stapedial reflex. So, to understand this, we should know that there is a stapedius muscle which is protecting us from the loud sound. So, whenever a very loud sound is presented to the cochlea, so this particular mechanism get activated and it protects us from the sound. So, stapedial reflex is involuntary bilateral contraction of the stapedius muscle due to excessive stimulation of the inner ear cochlea with the acoustically loud sound. And what is this sound? The ipsilateral acoustic reflex is measured at stimulus intensity of 70 to 90 decibel. Normal contralateral, this is the ipsilateral one side. Contralateral here, threshold is 5 to 10 decibel above the ipsilateral threshold. Now, where can we find abnormal stapedial reflex? Now, they are, you know that they are this particular mechanism, this particular pathway. If we know, then we will very well easily understand the pathologies of abnormal stapedial reflex. If there is something in the stapes muscle, so that is middle ear diseases, autosclerosis, ossicular discontinuity, or atelectasis. Then there is something in the seventh nerve. So before seventh nerve, let's talk about the stapedius muscle, because here this muscle is there. If there is post-stapedectomy, there is cutting of the stapedius muscle we do normally, and myasthenia gravis affecting the stapedius muscle. Then this particular nerve, where is it affected? Facial palsy, Ramsay-Hunt syndrome. Then it can be cochlea, seventh nerve, superior olivary complex lesion, little above. Severe SNHL, acoustic neuroma, multiple sclerosis, centrally originated diseases. So these are the all pathologies, etiologies behind the abnormal acoustic reflex. BERA, last audiometry test. So BERA is a hearing test which is objective test eliciting the brainstem potentials in response to audiological stimuli, which is mostly click stimuli. So we have to know that, first of all, it is objective. It is talking about the brainstem potentials, and here the thing we use is click stimuli. It is the investigation of choice for deafness in cases like infants, mentally retarded, or malingers. This is a question, very common question. For the assessment of the nature of deafness, it is conductive or sensorineural. and for identification of the site of lesion in retrocochlear pathologies. So these are the only points you need to know at this stage about beta. This is how we are done about hearing test using tunic fork and various audiometric assessment. I hope it will help you. Thank you.